Thanks for having me today. My name is Elizabeth Gay, and I'm one of the pulmonary faculty at Brigham and Women's, and I'm going to walk you through a challenging pulmonary case today. So this patient presents to her primary care physician's office and has a chief complaint of progressive shortness of breath. So she's a 55-year-old woman who notes a couple months of shortness of breath, which initially wasn't that bad, but has gotten progressively worse. And she also has a productive cough with some phlegm, and she's started having fevers. She's been to urgent care and has received 2 rounds of antibiotic therapy. They thought perhaps she had bronchitis, but really hasn't felt any better. So on further review of systems, you elicit the following from her. She has a long history of chronic sinus problems, more than a decade, has been treated for sinus infections. More recently, she's noted a foot drop when walking in her left foot, and also some kind of tender joints in her elbows and knees, wheezing with exertion, and some lower extremity edema, a few bumps on her arms, as she describes them, and just kind of feeling crummy in general with a lot of fatigue. She's not had weight loss, hemoptysis. She's not woken up at night short of breath, tinnitus, orthopnea, dizziness, or syncope. So her past medical history is notable for asthma. For many years, almost 10, she's been managed with an inhaled medium-dose corticosteroid, and generally had been pretty well controlled until about 6 months ago when she developed more symptoms, despite really no change in her therapy. At that point, montelukast was added, or Singulair, and before this year, she'd really rarely needed steroids. But this year she's had a bad year and has needed steroids several times. She's never been intubated or hospitalized for her asthma in the past. And then as mentioned before, she has a history of allergic rhinitis and sinusitis, this more recent diagnosis of foot drop, and then chronic problems of obesity, hypertension, and hyperlipidemia. And on exam in the office, she's febrile to 38.6, slightly tachycardic to 105, hypertensive. Her respiratory rate is a little bit fast, and she's saturating 92% on room air. But in general, she's not in any respiratory distress. She's no elevation in her jugular venous pulse. Her chest exam, however, is notable for scattered expiratory wheezes and some rhonchi. On cardiovascular exam, she's tachycardic with a somewhat distant S1 and S2, but no murmurs. And she's 1+ symmetric lower extremity edema. On her skin exam, she has some tender nodules on the extensor surfaces of her arms. And on neurologic exam, she has a left foot drop with weak dorsiflexion of her right wrist extensors as well. She obtained some labs, and she has a CBC that's notable for leukocytosis to 18,000 with 23% eosinophils. Otherwise, her chemistry is notable for a bicarb of 17 and a creatinine of 3.1 from a normal baseline. Her urine analysis is notable for 3+ blood and 1+ protein with no evidence of infection. This is an example of her skin finding with the tender nodule on the extensor surface of her arm. So just to pause for a moment to think about this patient, she comes to your office with numerous complaints in multi-system involvement. And so the question is, what would you do next in terms of trying to figure out what's going on with her? So because of her complaints of wheezing and shortness of breath, which is really her chief complaint in the office, she obtained pulmonary function tests. And we don't have a recent baseline on her, but several years ago, she had a spirometry, which was normal. And again, her asthma had been well controlled. At present, though, she has a decline in her FEV1 to 71% of predicted, with a ratio of FEV1 to FVC of 0.63. Diagnostic of obstructive lung disease. Her total lung capacity is normal at 100% of predicted, and her diffusing capacity is normal at 85% of predicted. So far we might say, well, maybe this is just poorly controlled asthma. She has a new obstruction. But you obtain a chest imaging. This is a PA and lateral chest x-ray, and the arrows here are pointing out some subtle nodular opacities, which is not what you were expecting. You'll recall that she's had 2 rounds of antibiotics without improvement. So you obtain a CAT scan, And the CAT scan, this is a representative slide, shows several areas of both consolidation, but also of more nodular areas. Because there are complaints of shortness of breath, you obtain an echocardiogram, and this is a representative image of a parasternal long image, which shows you the relationship of the left ventricle to the pericardial space. And here, labeled, you have fluid around the heart or pericardial effusion. So now the plot is thickening. She has multiple new problems. You obtain urine microscopy because of the renal failure, and you see casts in the urine. And these are red cell casts. So to stop and try to think about her again, we now have a woman who has a long-standing history of asthma, and now she's presenting with fever, systemic symptoms, pulmonary infiltrates that haven't responded to antibiotics, and new problems in multiple organ systems, including a neurologic exam that suggests a mononeuritis multiplex with foot drop, cutaneous nodules, and glomerulonephritis with an active sediment. And finally, she has a pericardial effusion suggesting pericarditis. So when you have somebody who presents like this woman with multi-organ involvement, one of the ways to think about this is to try to imagine what kind of disease could affect all these organs in this particular pattern, and what might lead us to that diagnosis. And so sometimes infection can cause multi-organ problems, but not usually in the subacute manner. So that leads us to think about inflammatory diseases. And of the inflammatory diseases, diseases that might affect both the small nerve and the skin, as well as the kidneys, include vasculitis. And so to think further about this, vasculitis is an inflammation of vessels and can range from very large vessel vasculitis, like giant cell arteritis, to small vessel vasculitis. And then there's some overlap with diseases that affect the medium-sized vessels. Think about the kind of presentation our patient has. She is having problems in really small to medium-sized vessels, kidney, skin, nerve fibers. And that helps us narrow the differential. And we really start focusing on the small vessel vasculitis. And so of the diseases that can affect the small vessels, there's an important group of diseases that are sometimes referred to as ANCA-associated vasculitis, or pauciimmune. And the pauciimmune term comes that when you biopsy lesions associated with these kind of vasculitis, you do not see immune complex deposition. And so the common small vessel vasculitis in this category include GPA, which is formerly known as Wegener's, microscopic polyangiitis, or MPA, and Sturge-Strauss syndrome, or eosinophilic granulomatosis with polyangiitis, or EGPA. And another way to distinguish these three, which can all cause multi-system organ involvement, is what kind of anti-neutrophil antibody they present with. And so most patients with MPA and EGPA have something called a perinuclear antibody staining pattern, whereas patients with GPA or Wegener's tend to have a C-ANCA pattern or cytoplasmic antibody pattern. And these antibodies correspond to particular antigens in the nucleus, including for P-ANCA vasculitis, something called MPO, and for C-ANCA vasculitis, this corresponds to the cytoplasmic antigen. So for our patient, we start sending a broad lab workup, trying to associate her symptoms with the potential for vasculitis or for our connective tissue disease. Her initial testing for things like lupus and rheumatoid arthritis is negative, and she has no evidence of acute or chronic viral infection. She does have a positive anti-myeloperoxidase or MPO antibody, again associated with P-ANCA. The anti-proteinase 3, which is associated with C-ANCA, is negative, and she has normal complement levels and evidence of systemic inflammation with an elevated ESR. She then undergoes a renal biopsy, and a representative slice is shown here. And what this shows is something called a crescentic vasculitis, where you have a rapid progression of destruction of the glomeruli, but staining does not show any positivity for immune complement deposition. So this falls into the category, as mentioned before, of pauci-immune glomerulonephritis. So she meets the criteria for EGPA, again, formerly known as Sjögren-Strauss syndrome. And this is an ANCA-associated vasculitis that, although it is the least common of the ANCA-associated vasculitis, it's important because it often presents in a somewhat confusing way, in that most patients have a long-standing history of asthma, up to 10 years of asthma in many cases. And they may really be treated only as allergic asthma, even as their asthma worsens, unless you have a high suspicion for a new process. And so the phases of EGPA include early asthma and sinus disease. And again, this may precede development of overt tissue infiltration by eosinophils and vasculitis by a decade. In the next phase, you get eosinophils, and you'll find eosinophilia, as our patient had in the blood. And these eosinophils can infiltrate any organ. One of the less common features of EGPA, but most morbid features, is infiltration of the heart, or cardiomyopathy. And finally, there's the third phase, which is a true vasculitis. And this is the phase that tends to cause skin involvement and also renal involvement. The renal involvement in EGPA, as opposed to other ANCA-associated vasculitis, is actually much less common, as opposed to up to 80% in GPA or microscopic polyangiitis. It's only probably a quarter of patients in EGPA. Interestingly enough, ANCA is only positive in somewhere between 40 and 60% of patients with EGPA, again, making this a quite challenging diagnosis at times. Again, and this is in contrast to ANCA positivity, which is much more common in GPA or microscopic polyangiitis. In addition to skin, renal, and pulmonary involvement, peripheral neuropathy, including what our patient had, which is isolated mononeuritis multiplex, is seen in up to 75% of cases. So that can be a clue. So the lung disease in EGPA, as mentioned, initially it starts out as asthma. And then this asthma may become more difficult to control. It's marked by eosinophilia in the periphery, so eosinophilic asthma. But then patients may actually develop parenchymal involvement, as our patient did. Classically, these are described as waxing and waning infiltrates. So patients may be treated for pneumonia over and over again. And sometimes it's hard to know if this was actually something that was infectious or responded to steroids, because many patients with asthma, when treated for infection, will also be given prednisone. Less common, but also potential pulmonary manifestations of EGPA include pleural effusions, which may be eosinophilic, nodules, which may cavitate, and rarely diffuse alveolar hemorrhage. As I briefly alluded to, heart disease is important in EGPA. It's not as common as lung disease. Probably only about 20% of patients develop heart disease, but it's responsible for many of the deaths from EGPA. And it can really affect the heart in almost any way, including causing heart failure from an infiltrative cardiomyopathy, pericarditis, as our patient had, and conduction disease. Interestingly, heart disease is more common in patients who have a negative ANCA, but may be associated with a higher eosinophilic count at diagnosis. And these are biopsy slides from endomyocardial biopsies showing eosinophilic infiltration. So the pathophysiology of ANCA-associated vasculitis is not fully understood. The anti-neutrophil cytoplastic antibodies themselves are probably pathogenic, but they cannot clearly explain all of the disease, since a good portion of patients with EGPA do not test positive for the ANCAs that we routinely test for. But almost all patients have evidence of damage and degranulation of neutrophils, which sort of perpetuates inflammation, which can damage the tissues. And then in EGPA in particular, the eosinophils themselves damage the vessels, and you'll find both necrotizing and eosinophilic granulomatous inflammation on biopsy. So initially, therapy for the ANCA-associated vasculitis has really focused on immunosuppression, with the standard of care being high-dose steroids for induction, often what we consider pulse dose steroids, then followed by some kind of longer-acting immunosuppression. It may be B-cell targeted, like rituximab, which has been studied particularly in C-ANCA-associated vasculitis, or Cytoxan, which affects both T and B cells. Although these therapies are effective, they carry with them a lot of risk of infection and long-term morbidity for the patient. So there's been an interest in developing more targeted therapy. And the interesting part about EGPA is that the eosinophil turns out to be a natural target because for many years, people have been focusing on the role of the eosinophil in allergic eosinophilic asthma. And so there's a drug called mepolizumab, which by targeting the IL-5 receptor prevents the maturation and survival of the eosinophils. And when this has been looked at in EGPA, it has shown a fairly impressive increase in placing disease into remission and also decreasing rates of relapse without the burden of infection that you see with typical immunosuppression. So this has really changed the landscape for treatment of EGPA. And it's also worth pointing out that EGPA may live on a spectrum with other kinds of severe allergic asthma. And again, because the ANCA testing is not reliable, if somebody has allergic asthma with a large amount of eosinophils, even if they don't have a very clear evidence of vasculitis, mepolizumab at the higher dose, which is used for vasculitis as opposed to asthma, may be worth considering, again, as EGPA is probably a disease that evolves over decades. And if you can prevent the increase in eosinophils, which eventually leads to tissue penetration, you can actually spare people a lot of morbidity. So this is an evolving area, but one of considerable interest. Okay, so I'm just going to go through a couple of questions here at the end related to similar cases. I should, though, before I go to the questions, just let you know that this patient, again, met criteria for EGPA because of her positive ANCA and also a consistent renal biopsy. And she was started on high-dose steroids initially and received both Rituxan, but then began receiving mepolizumab at 300 milligrams monthly, which is the higher dose used for vasculitis. And with this combination of therapy, she had actually very good remission of both her neurologic symptoms, her skin rash, and her pulmonary symptoms. The pericarditis did not go away until she received mepolizumab. It had not been a steroid responsive, so that was interesting. And she's doing well now and is only on mepolizumab and actually not on any steroids now for maintenance. The thought for this disease, though, is she'll need lifelong therapy because there's a high risk of recurrence if you stop the mepolizumab, and the recurrence may be life-threatening. So thank you. So back to questions. So for this first question, this is a 50-year-old woman who presents with shortness of breath and hemoptysis. And she had been fairly well until a few weeks prior to presentation when she noted shortness of breath and some lower extremity edema. And then more acutely, she developed dyspnea and began coughing up blood. She presented to the emergency room and was hypertensive and hypoxemic. She noted to be pale with both lower extremity edema and some crackles on her lung exam. And her lab work revealed a acute kidney injury. It was also positive for a C-ANCA. The question about this case is, which of the following is the most likely finding on a subsequent renal biopsy? Answer A is positive staining for complement. Answer B is fibroepithelial crescents with collapsed glomerular tufts. Answer C is tubular dilation and necrosis. And answer D is thrombi and glomerular capillaries. So the correct answer here is what we call crescentic glomerulonephritis. And to walk through these choices, the choice A, positive staining for complement, would imply a disease that's mediated by complement, for example, an IgA nephropathy. And again, the ANCA-positive vasculitis are post-immune, so you do not have positive staining for complement or IgG or IgA by definition. Answer C, tubular dilation necrosis, is a pathology of acute tubular necrosis or ATN, which is typically associated with either a prolonged prerenal state or a hypotension. And our patient does not have a history that would suggest that she would be at risk for ATN. And answer D, thrombi in glomerular capillaritis could be associated with a microscopic thrombi formation, but that would not be classic for ANCA-positive vasculitis. And so B is the correct answer. And again, what you typically see is a rapidly progressive crescentic glomerular nephritis, as we saw in the biopsy for our patient. And question 2 is about a 42-year-old non-smoking man who presents with shortness of breath and also for hemoptysis. He's also noted some epistaxis and decreasing urine output, but no hematuria. On review of systems, he has some tingling and numbness of his fingers and toes, and then actually a longer history of joint pain. On exam, he's pale, tachycardic, and hypertensive, and requires supplemental oxygen to keep his saturations up. He has a normal chest exam, but decreased reflexes on his neurologic exam at both knees and ankles. And his lab testing is also positive for a c-ANCA, or antigen directed at PR3. And so the question is, which of the following are most likely to be found on CT scan of the chest? Answer A, a large left-sided pleural effusion. Answer B, normal lung parenchyma. Answer C, scattered cavitary lung lesions around 1 centimeter. And then answer D, lower lobe predominant fibrotic changes. So the correct answer for this question is C, scattered cavitary lung lesions. And so although for A, a large pleural effusion, you can have a pleural effusion in ANCA-associated vasculitis, you'd expect a finding on exam of a decreased breath sounds on the left side. It's also a fairly rare presentation of vasculitis. B, normal lung parenchyma is possible based on the exam, but it'd be unusual that he would require oxygen if his lung parenchyma were entirely normal. Answer D, lower lobe predominant fibrotic changes. Although pulmonary fibrosis is a very rare manifestation of ANCA-associated vasculitis, again, you would expect some finding on exam, which was missing. And it would also be probably the least common presentation of pulmonary manifestations of ANCA-associated vasculitis. So we're up to C, scattered cavitary lung lesions. And this is a common presentation of ANCA-associated vasculitis. You may not hear much on exam, but if there are enough of these lesions, they can affect your physiology, as they probably are for this patient. So that would probably be the most common finding based on this patient's exam and vital signs. Thank you.